I'd like to welcome you all for joining us this evening to our webinar, Best Clinical Practices for Patients with Inherited Retinal Diseases. And before we begin tonight's presentation, I would like to briefly review some details regarding Zoom user controls and audience interaction. Currently, all attendee lines are muted and without video. All user controls are located at the bottom of the Zoom screen, and depending on your setup, the control bar may automatically hide itself when not in use. So if you prefer the control bar to stay visible throughout the presentation, please use the following keyboard shortcuts. On Windows, simply press the Alt key, and on Mac, press the Control plus backslash key to make sure that your control bar is visible. And tonight's presentation will be recorded and closed captioning is available. And to activate captions, please select the More button with the three dots on the bottom right of the control bar. Select Captions, then select Show Captions, and you'll have the captions available. During the course of the call, you will be able to ask questions via the Q&A or chat feature, both of which are located in the controls at the bottom of your screens. Questions will be answered at the end of the presentation during the dedicated Q&A portion. And if for any reason we don't have time to answer your question, we will follow up with you. So please include your name when submitting your questions. Questions can also be submitted via email to po@fightingblindness.org. So with all the housekeeping out of the way, I'd like to hand things back over to our Director of Professional Outreach, Michelle Glaze. Michelle.
Thank you. Welcome and good evening, everyone. I'm Michelle Glaze, Director of Professional Outreach for the Foundation Fighting Blindness, global leader in driving retinal degenerative disease research. Our professional outreach team is delighted tonight to host this Best Clinical Practices for Patients with Inherited Retinal Disease webinar. Through professional outreach, we seek to empower eye care professionals to provide knowledge, community, and hope to patients with retinal degenerative disease and their families as they go through their personal journeys with vision loss. During tonight's presentation, you're going to hear a robust discussion from two remarkable key thought leaders in the field. They are going to highlight a path for you to provide hope for patients as you are providing the best clinical care and management of patients with inherited retinal diseases. You will hear coverage on the discussion on the continuity of care. You'll hear about genetic testing, low vision rehabilitation, clinical diagnostics, and clinical research. I'm excited to introduce our two key thought leaders for tonight's presentation. Dr. Rachelle Huckfeldt, MD, PhD. Dr. Huckfeldt is Assistant Professor of Ophthalmology at Harvard Medical Center. She is also a clinician and scientist at Massachusetts Eye and Ear. Dr. Huckfeldt completed her MD and PhD training at Washington University in St. Louis. Her PhD is in research and retinal development, and Dr. Huckfeldt has had the opportunity to conduct research for novel therapeutics with some very prestigious labs. I'd also like to introduce Dr. Rachelle Lynn, ODMS, FAAO. Dr. Lynn is Assistant Professor of Optometry at Southern California College of Optometry at Marshall B. Ketchum University. Dr. Lynn teaches low vision rehabilitation and genetics at SCCO. She also provides patient care for low vision patients and genetic testing to patients with inherited eye conditions. Dr. Lynn received her doctorate of optometry and Master of Science in Visual Sciences at Southern California College of Optometry. I'd like to turn it over now to Dr. Huckfeldt and Dr. Lynn. Thank you.
Thank you, Michelle. Thank you, FFB, for having us. I'm going to kick off the talk first with an intro to diagnosis for IRDs, inherited retinal dystrophies. And I know we always like to say it's rare until it's in your chair. And those of us who are in clinical practice, when these patients do come along, it is important that we know the resources that are available to them and the best practices moving forward. Not only are these conditions associated with potential syndromic conditions, these conditions can have high risk for morbidity and mortality. And on the positive side, some of these conditions do have treatments. So what are IRDs? And what are we encompassing? IRDs are very clinically heterogeneous. Sure, they're rare, but when we do see them, we do need to take a very close look to find out not only the genetic diagnosis, but the phenotypic presentation for that particular patient. Why is that the case? Well, there's high phenotypic variability and phenotypic overlap with these conditions. Oftentimes, it is very difficult to diagnose these conditions simply based off of the clinical presentation or what the fundus looks like. Many of the conditions can look very similar, particularly in early and or very late stages. And even among family members that have the exact same gene mutation, their presentations can vary widely. On top of that, there's a lot of genotypic heterogeneity as well. Some of these conditions are associated with many different genes and various mutations on those various genes. And some of the genes are associated with multiple clinical presentations. What are our current recommendations for assessment of patients with IRDs? Well, one excellent resource is the American Academy of Ophthalmology's guidelines on clinical assessment of patients with inherited retinal degenerations, which was recently updated in 2022. In this document, the clinical phenotypes are broken down into 4 main categories. Number 1, the rod cone degenerations, the conditions that affect the rods earlier and more severely than the cones, for example, are RPs, retinitis pigmentosa. Number 2, the cone rod degenerations. Number 3, the chorioretinal degenerations, for example, choroideremia. And then number 4, inherited dystrophies that involve the macula. And this could include our cone degenerations, X-linked retinoschisis, and Stargardt disease. If we look at those 4 categories within the document from the American Academy of Ophthalmology, they have an excellent chart that lists out all of the tests that would be part of that comprehensive clinical assessment. And that's the chart over to the right. In summary, though, what that assessment would include is number 1, a very comprehensive history, not only the ocular history, but also the systemic history for that patient, as well as family members. This then leads into creating a thorough pedigree. We like to go for as many generations as we have knowledge for, but at least 3 generations is excellent. Thirdly, the clinical eye examination. That would include your slit lamp examination, eye pressures, fundus evaluation, additional imaging, for example, OCTs, visual fields, electroretinography testing, and last but not least, genetic diagnostic testing. Within this most recent update of the guideline from the AAO, they do specifically note that genetic diagnostic testing is recommended for all 4 of those clinical phenotypes that we mentioned. So for all those IRDs, we are recommending diagnostic testing of the genetics. In addition to that, there is a note that if the patient has had inconclusive testing in the past, it is recommended to redo that testing because our test panels have improved over time. What are we talking about when we discuss genetic testing? Well, we can also rely on the American Academy of Ophthalmology's genetic testing guidelines and recommendations. And within their document, they talk about these 5 components. Number 1, there's a clinical determination of the presence of a genetic eye disease. We shouldn't be running into a genetic test blind. We should be saying, we know what the differential diagnoses are. Let us choose an appropriate test panel that includes the genes of concern so that we are making an appropriate test for a condition that we know is most likely an inherited eye disease. Secondly, we would collect the sample and send that to the lab. Thirdly, the lab would then analyze that genetic information and create a report. Number 4, that report then goes back to the ordering provider. This is a very important component because And it involves interpreting the results of the genetic test report within the context of the patient's clinical findings. And last but not least, patient counseling. Genetic testing is not that useful if the patients do not understand the results or that those results are not conveyed to the patient. So genetic testing and genetic counseling are highly recommended for the patients. And if we are going to pursue genetic testing for the patient, we do want to make sure that all 5 components are taken into account. Has genetic testing improved over the past few decades? Absolutely. This is a graph from the RetNet website that shows if we look back 10 years, 20 years, 30 years, there was a lot less that we understood about IRD genes. Therefore, when we're doing a genetic test now, the genetic test panels are far more comprehensive than what was available 5, 10, 15 years ago. If a patient's had a negative test in the past, that's when we recommend that it might be worthwhile for them to consider retesting now. So here's a question that comes up. Why can't we just do genetic testing to diagnose everyone? Why do we still rely on all of our clinical examination findings? Well, even with our best current panels and everything we know about IRDs, genetic testing can still be inconclusive or come out negative. And this is important to discuss with patients beforehand so that they have reasonable expectations about the testing. Causative mutations can be identified in up to 56 to 76% of patients with IRDs. This means that a good percentage of patients might come up with a negative test. That doesn't mean that their RP is not genetic in cause. It just means that we currently are not able to identify the pathogenic mutations that are causing their particular condition. We may consider retesting in the future. So with that, I'm going to pass it back to Dr. Huckfeldt so she can go a little bit deeper on diagnostic evaluation and genetic testing.
Thank you, Rachelle. I'm just moving over to my screen. And I also want to thank Michelle and all the people who made tonight happen. And it's just a pleasure to be here talking to you all. I'm going to try to build off some of the wonderful points that Rachelle made and give you a sense of what we do when a patient comes to our very specialized IRD-focused clinic at Mass Eye and Ear. Using some of the same parameters that Rachelle showed in the FAAO best practices table, we use all the clinical tools at our disposal as relevant and appropriate to understand someone's vision, how it works, the underlying disruption of the retina, to answer the question, do we think that this is a hereditary condition? Or is it possible that it's more in this sometimes gray zone of an atypical acquired condition? We think it's hereditary. Of course, we are going to advise genetic testing, which I'll talk about more in a moment. And then I also want to touch on the types of non-IRD things we're looking for when patients come back to see us. What are opportunities to intervene and act and treat some of the findings that can be associated with an IRD? And then finally, a really important part of visits to my clinic is making sure that people are set up with all of the appropriate resources, whether this is a low vision optometrist, whether this is a mental health provider. We want to make sure that none of those resources are being missed. I'd like to start with a case, not so much to talk about the specifics, but to show you how all of these different assessments of visual function and retinal structure might come together in an initial visit. So this was a woman who came to me as a new patient a number of years ago with a long-standing history of congenital hearing loss, more recent changes in her vision. We, of course, checked her visual acuity, which was a little subnormal. We did Goldmann perimetry, which has the advantage of showing us the entirety of the visual field, not just the central portion that showed constriction. Full field ERG showed abnormalities of scotopic and photopic function. And then in our standard panel of retinal imaging and exam, of course, we saw some of the characteristic findings of RP. And we look at the autofluorescence, for example, the OCT, and we think about how that structure corresponds to what we're seeing in our functional testing and what the patient is complaining of. Based upon the history of hearing loss and the clinical information that you see on this slide, it was pretty clear to us that the clinical diagnosis was Usher syndrome type 2. So as Rachelle alluded to, we are not infrequently finding syndromic conditions in patients who come to us only because they think they have a retina problem. We did genetic testing, and that clinical diagnosis was really corroborated by finding 2 disease-causing mutations in the gene USH2A, which is the most common cause, not just of Usher syndrome, but also of autosomal recessive RP. So this was, again, a first-time visit for this patient. We thought about her history. We thought what tools might be helpful. And again, in line with the table Rachelle showed, when someone like this comes back for follow-up, we're going to be more selective in which assessments we choose and think about what do we need to find information to help us understand the course. I want to come back to genetic testing, and I'm so happy that Rachelle highlighted the 2022 AAO guidelines. That was something that was also recommended, or the importance of genetic testing for IRDs in 2014. And I've highlighted a few things that I think are important about both of these papers. They both really emphasize the importance of genetic counseling. And whoever provides this, there needs to be adequate pre-test and post-test counseling for some of the reasons that Rachelle already mentioned. I also really like the 2014 paper because it touches on the idea of risk. Genetic testing is not a risk-free endeavor for a reason I'll touch on in a moment. Rachelle posed the question of, well, why not do genetic testing? A question I often get is, well, why does it matter? If you aren't going to necessarily be able to give me a treatment right now because of my genetic diagnosis, why does it matter? And I have 3 general answers for this. One is just the immediate relevance of the information for affected individuals. We see over and over that people have sort of scattered and unexplained and seemingly unrelated systemic findings in addition to their retinal disease that often have gone unanswered for many years. And to highlight that, there's a very specific appearing chorioretinopathy that, as shown in the pictures on the right, can be accompanied by microcephaly, by swelling or lymphedema in infancy, and intellectual disability. And it turns out there's a gene that goes with this constellation, has maybe recognized about a decade ago. And a number of years ago, I saw a patient recognized what this was, confirmed it with genetic testing, and it was just this relief for the parents of this adult. They had for many years had this nagging sense that maybe there was more to these scattered things than anyone had realized. And even though I couldn't, do anything to address the retinopathy, this knowledge had power for them. Sometimes we realize the relationship between these seemingly unrelated systemic findings and something like retinitis pigmentosa, and they do have actionable consequences for someone's overall health. Retinitis pigmentosa accompanied with lack of smell, abnormalities of the metatarsals as shown in the picture on the right, and dry skin or ichthyosis, as well as other systemic findings, comprise the syndrome of Ressam disease, in which there's a specific mutation in an enzyme that causes abnormal amino acid metabolism. And it's a condition where once we recognize it, we advise a low phytanic acid diet in the thought that it will impact the progression of disease. So that's an actionable genetic diagnosis. And then the risk and the seriousness of genetic testing comes to the fore when sometimes ophthalmologists and optometrists are really the first people to recognize or make a genetic diagnosis that has really severe really consequences for not just systemic health, but life expectancy. And Batten disease, which is a neuronal ceroid lipofuscinosis accompanied by early onset dementia, is the pit in my stomach condition that comes to mind. Genetic testing and a genetic diagnosis also has relevant information for families. I'm not going to go through these examples, but I can think of all kinds of examples in which the best drawn pedigree just doesn't have the right information or has misleading information in terms of helping you understand the mode of inheritance. And getting that mode of inheritance correct is really important for families as they think about risk to other individuals, as they think about risk to future children and all these kinds of factors. And then although it's rare, every now and then, even though, maybe there's multiple generations of one gene causing disease in a family, every now and then we'll find a second gene in there that we wouldn't have, known to even think about had we not done genetic testing. And then finally, getting a genetic diagnosis is really a future-oriented action, right? With the approval of Luxturna in 2017, really has given us tremendous optimism that we are looking forward to a future with more and more gene-specific treatments. So I think this is important information for any patient with an IRD that orients our attention not just for now, but for the future. Here's a question that Rachelle asked already. Well, why can't we just go straight to genetic diagnosis? And the reason we can't is because of the complexity of how all of these genes produce their clinical phenotypes. In this Venn diagram, each circle encompasses a clinical diagnosis with all the genes that cause it included in the circle. And you can see this tremendous overlap of all these circles with RP. And I don't think I have my pointer on, but there's one gene in particular, RPGR, that can cause X-linked RP. It can also cause X-linked cone rod dystrophy. And right now, it really matters that we get that phenotype correct. There's a investigational gene therapy where the clinical trials are open to people with RPGR, X-linked RP, but not RPGR, X-linked cone rod dystrophy. So the phenotyping really helps us understand how these genetic changes are manifesting. And as Rachelle said, many of our patients with clear clinical evidence of inherited retinal disorders are so-called unsolved after genetic testing. And with the hope that there will someday be a genetic diagnosis for them, the phenotype helps us to interpret those results. I'd like to turn, though, to the other things I'm looking for when patients come in to me for follow-up. I'll start with cataracts. We know that early PSC in particular is common, for example, in patients with RP, and it can cause major disability and impact on functional vision because of how it impacts visual acuity and increased glare. There are intra and perioperative considerations that our cataract surgeons at Mass Eye and Ear and elsewhere take into account when they're operating on eyes with RP. But these factors don't preclude, obviously, having a safe and successful surgery. And as we think about, the person in our chair with a cataract and their post-operative, potential outcomes, we know that better visual acuity at baseline and a better preserved ellipsoid zone on OCT at baseline are predictors of better post-op visual acuity. That said, it is such a personal decision. The fundus images on the right belong to two of my patients. The first one with really prominent PSC preoperatively had really nice ellipsoid zone underneath that. He went from about 20/80 to 20/30 with cataract surgery, had a profound improvement on his visual function and his quality of life. The person on the bottom had enough macular atrophy that we had a hard time getting a high quality OCT. This individual went from hand motion to count fingers, and that was a really meaningful change for him. He was really happy he had surgery. So any decision about cataract surgery really needs to be individualized to the person who's thinking about it and their retinal status at that moment. I'm also looking for cystoid macular edema, or CME. This is something that easily affects at least 25% of people with RP and other inherited retinal disorders. And we want to treat it when it reaches the point of being anatomically significant and visually significant. So the top OCT is from one of my patients with X-linked RP. We started dorzolamide as an eye drop based on the OCT appearance. He actually was worse, both anatomically and functionally, when he came back. So we switched to an oral version of a carbonic anhydrase inhibitor, acetazolamide. And when he came back, he was so happy. He was aware of the change in his vision. I was happy with his OCT, and we've kept him there. If he goes on vacation and forgets his medicine, he knows the edema is coming back. He's very sensitive to it, but the acetazolamide has kept it under control. And then rarely, but importantly, sometimes we see choroidal neovascularization, or CNV, in IRD patients. In this patient with choroideremia, he came in complaining of a pretty sudden change in his vision. And in the right eye, you see kind of messy looking hyperreflective material underneath the fovea. His visual acuity was much lower than in the other eye. If you're very observant, you'll notice a little tinge of blood on the fundus image. And after one injection of an anti-VEGF therapy, his vision was back to 20/20. So I, warn all my IRD patients that if there's a sudden change in their vision, they really need to get it checked out right away. I'm not going to talk about mental health, but that's obviously important. And as I already mentioned, we are so grateful for our low vision colleagues for all the benefits and resources that they provide. So I'll turn it back over to Rachelle at this point.
Thank you. Let me pull up the share screen. There we go. All right, low vision resources. So I work within the low vision department at our university associated with Ketchum Health Clinic. And within that clinic, we do all of our testing for patients with IRDs. What does that low vision evaluation look like when you refer a patient over? Well, number one, we're going to get a very thorough case history. This can include the family pedigree, but it also includes things such as the patient's goals. Where are they going to school? What are they studying? What types of things do they want to accomplish within their work environment, for example? So we really get the opportunity to get to know the patient. Number two, we are not using charts that the patient cannot see. We want to focus on what the patient can see. So we will have large print charts, such as the Bailey-Lovie chart or the Feinblum chart, so that we can assess the vision as thoroughly as possible. Instead of refracting the patient behind a phoropter, as we might with a patient who has 20/20 vision, we will typically do a trial frame refraction. And there are many benefits to this. One of the main benefits is that we can show larger lens changes. It's going to be very difficult for a patient who has vision loss to select between a quarter diopter lens change. So we'll do larger lens changes based on their visual acuity. Behind the trial frame, it's also more realistic for the patient. They're not behind an instrument. If the patient has a head tilt or a high prescription where the vertex distance makes a difference, or if we even want to trial add-ons such as special tints or telescopes, we can do that within the trial frame. After we find the patient's best corrected visual acuities, then we will go on to device demonstrations. That device demonstration will then include training for the devices that we recommend, and we can also include filter and lighting assessment. So let's show you some of the devices that might pop up within that low vision evaluation. Of course, we have our traditional near magnification devices that are very commonly seen, such as our handheld magnifiers and stand magnifiers. Typically, over-the-counter ones come in lower powers and they might not have good optical qualities or lighting. So we are showing the patient magnifiers that may be much more powerful than the ones they can get over the counter. Traditional distance magnification devices include our handheld monocular telescopes, binoculars, as well as bioptic telescopes. So on the right side, we have an example of a bioptic telescope where the patient is able to look through the carrier lens when they're driving, for example. And then when they do need to spot read something that's a little bit smaller, they can tip their head to look through the magnification portion of the telescope. Filters. There are different light filter colors that we may recommend or trial with the patients. For example, for enhancing contrast, yellow can help some patients, and there are specific colors for particular eye conditions, for example, red colors for patients with achromatopsia and cone dystrophy. Then we get into the more high-tech devices, for example, our CCTVs, portable digital magnification devices, tablets that are specifically designed for low vision, optical character recognition software, so that's our text-to-speech software, and then also wearable devices that include magnification and contrast enhancement. Nowadays, a lot of our younger or more tech-savvy patients will use cell phone apps, for example, Seeing AI cell phone app, to be able to use the text-to-speech software on that. And sometimes simple is best. For example, if I have a patient who just wants to play bridge, I might ask, has she just tried larger print playing cards? There are many large print everything that you can purchase online. For example, these large print keyboards or large print clocks, and sometimes other recommendations to the patient that they might not have thought of. For example, if they're having difficulty chopping white onions, why not try using a black cutting board for contrast? Where can you find these low vision resources for your patients? Here are some options. On the American Optometric Association's website, there is a Find a Doctor resource where you can select for practice service of vision rehabilitation or special emphasis of low vision and rehabilitative vision. So that is one place you can search for doctors of optometry who do low vision within their practice. Of course, there are many organizations such as AFB, American Foundation for the Blind, that list a lot of resources, as well as state agencies for the blind, such as the Department of Rehabilitation. We might not do everything in-house at a low vision evaluation. For example, we send referrals out for many different types of training. One of them is orientation and mobility training. You may hear this as O&M. Orientation and mobility training includes training on proper white cane use, and also patients would then prepare to learn how to use a guide dog or a dog guide. If patients do qualify to have a dog guide, there are specific and special schools that they would go to where they would learn to use a dog guide. We do have patients who drive, and many who drive very safely. For these patients, we can recommend driving assessment and training. These training facilities, some of them have both simulated behind the wheel assessments and then actually within a car with an occupational therapist or driving instructor training. This can also include bioptic training if that is something that the patient requires for driving. And of course, we're happy to fill out DMV forms. Depending on your state and your region, you may also have access to transportation services for patients who cannot drive themselves. For example, dial-a-ride or access services, but that's very regional, so you'll have to figure out what's available in your area. And then occupational therapy. There are occupational therapists who are specially trained in vision rehabilitation, and they can help with things such as eccentric viewing training, scanning training, and also in-home evaluations for safety, lighting, and labeling devices. And a couple more referrals that we might make. If the institution that the patient is at does not have all of the devices for additional clinical testing, we can certainly refer out for that. If the patient needs genetic counseling, or it's been a couple years since they've had genetic counseling and they have additional questions, we can refer for genetic counseling. And last but not least, we can refer for clinical trials. So with that, we'll hand it back over to you.
Thank you. 1 second here. All right. So as kind of Michelle alluded to in the introduction, I have the privilege of spending a lot of my time thinking about and working on clinical trials. And even though these are investigational therapies, we don't know if they work. That's why we need clinical trials to test them. I just want to stress that they are based on years and sometimes decades of really careful, step-by-step, rigorous science. And they are clearly a major source of hope for IRD patients, even if there's not a trial at that moment that someone can participate in. I could spend an hour talking about the types of therapies currently under development, but just to give you a tip of the iceberg sense of what is underway, we have multiple trials ongoing right now of neuroprotective agents that, whether they're delivered orally, genetically, or by stem cells, the hypothesis is that they can protect the health of the retina and slow down the degeneration. We have gene-specific treatments that ask some of the same questions. Can we slow down the rate of change or maybe even improve it? I'll get to that more in a second. And then we think about vision restoration approaches. Can we use stem cells, retinal chips, or optogenetics to improve vision in areas of the retina where there aren't enough photoreceptors or retinal pigment epithelium to target with a genetic therapy? When we think about genetic therapies, we have different targets and we have different approaches. So gene replacement or augmentation, the Luxturna type of drug, works at a DNA level by introducing a new copy of the gene. Genome editing, which you may hear referred to as CRISPR-Cas, also works at a DNA level, but by editing the actual chromosomal DNA that someone was born with. And both of these therapies are largely delivered by subretinal injection during a vitrectomy. If you think about the central dogma, right, DNA to RNA to protein, that gives us other opportunities to intervene. And so antisense oligos are an intravitreal therapy that can be used to target RNA. And there have been multiple trials to date of that type of approach for IRDs. And then just like we have genome editing, we will see RNA editing coming to the clinic as a therapy in the near future. All of these investigational therapies are tested in a very carefully controlled and regimented series of phases of clinical research that, again, always start after there's been very careful work in the lab and in animal models to make these therapies as safe as possible, assess their safety, and of course, make sure that they're efficacious in laboratory models before moving to people. Traditionally in clinical trials, we think about a first phase looking only at safety using normal volunteers before moving on to phase 2 and phase 3, looking at efficacy in individuals with the condition of interest. The reality for rare diseases like IRDs is that phase 1 and 2 often get lumped together. So the very first in-human efforts to test some of these drugs are being done in people with the condition in question. If you have a patient who is interested in clinical trials, or you wonder, I know my patient has this condition or this mutation, how can you find something that's relevant to them? And I would advise you that clinicaltrials.gov is a good starting point. I pulled up the website, I put in RP as the condition of interest, and I chose to only look for studies that are recruiting or recruiting soon. And before I show you the results of that search, I really want to stress this disclaimer here. Clinicaltrials.gov, that .gov sounds like a really official place that everything is vetted and should be there. But in reality, it does not take much to get a quote unquote trial listed here. So some of these should be read with a grain of caution. And I say that because there are quote unquote treatments that we know have blinded people. And this is a New England Journal of Medicine report talking about a clinic in Florida where the use of a particular type of so-called stem cell actually blinded 3 individuals with AMD. But to come back to my search with those terms, I found 65 studies. That's a lot. What if I want to restrict my focus to phase 3 studies that are interventional and happening in the US? When I do that, I get 1 phase 3 study. So this is a helpful tool for finding the type of study that is most of interest to a specific patient. I also want to thank and acknowledge Ben Shaberman because he keeps a really nice active list of trials on the FFB website. So fightingblindness.org, clinical trial pipeline. And one of the reasons I wanted to stress the phases of trials and the type of interventions is because the intersection of those two things really impacts the amount of risk that a participant encounters. If we have a phase 1/2 trial, so a first in human treatment, and if it's something like a virus-based gene therapy that's being delivered subretinally, there's non-trivial risk. At this point, we don't have any human safety or efficacy data. We know that there is just inherent risk with any type of vitrectomy surgery. We add to that the specific risks of the subretinal injection and the virus itself. And those are things that a potential participant has to consider carefully. In contrast, by the time we get to a phase 3 trial, we've been through phase 1 and 2. We have a sense of what the risks are. We know how to hopefully ameliorate them. And in the case of, the one trial that my clinicaltrials.gov search landed on, this is of an oral medication that's already FDA approved for a different indication that gives us a sense of safety. And there's also good short-term safety data from the earlier studies in RP. So different stages, different risks, but I also want to stress that there is no guarantee of benefit at any of these stages of a clinical trial. All clinical trials really put a heavy time burden on their participants, and these vary a little bit as well across stages. So any phase 1-2 trial involving a surgery means that I will be seeing a participant anywhere from 12 to 16 times in their first year of treatment. Genetic treatments or therapies or trials, those patients are followed for 5 years after treatment. And although the visit frequency falls to every 6 to 12 months, there's a long list of assessments being performed at every visit so we can best understand any efficacy and risks associated with the treatment. By the time a therapy gets to phase 3, we have a better sense of safety. We have a better sense of what outcome measures we're looking at that can together result in maybe fewer visits and hopefully a more tailored list of assessments. But I hope what I've sort of painted for you is that clinical trials ask a lot with no guarantees for the people who participate in them. And it is such an individual decision for an eligible person whether a trial makes sense for them. And there's, no wrong or right answer. It's just highly individual. And we're mostly just happy to have these opportunities to talk to people about. There are other ways to participate in research. I want to highlight the Foundation Fighting Blindness Clinical Consortium. The consortium is comprised of over 40 sites now in 16 countries on multiple continents. And our goal is really to do foundational research that will accelerate the development of treatments for IRDs. We have completed one natural history study for which the data has already been influential and impactful. We have others underway. And we have a study that is currently recruiting. It's called UniRare for short. We're going to get the clinicaltrials.gov link in the chat. But in brief, this is a study that's open to individuals with IRDs caused by more than 200 genes. It will eventually enroll 1,500 people. For most of those people, participation will involve only a one-time clinic visit that can coincide with when they're seeing their clinician already. For a subset of patients, there will be natural history studies. But this is, another way that motivated patients really can, in a meaningful way, help support research efforts for their diseases. And with that, I am going to have Rachelle come back on. I think Ben is coming on too, because I am certainly grateful for the optometrists, the vision rehab experts, and all the different resources in my community. And happy that there are people with Rachelle who have expertise that I certainly do not.
And Rachel and Rachelle, thanks for a really wonderful, comprehensive, and clear overview of best practices for clinical care for IRD patients. And I want to encourage attendees, if they have questions, to type them into the chat. We will take your questions, but I'd like to get things kicked off by talking about how, Rachel and Rachelle, you refer to each other, refer a patient to each other and collaborate. And Rachelle, let's start with you. I think it's important. Well, obviously, there are a lot of optometrists out there. Optometrists are the dominant eye care professional. And so a lot of people come through your door first. And what do you typically do when you have an IRD patient, let's say somebody with RP? And then when do you refer them on to someone like Rachel?
So I think it really depends on the setting that the optometrist is in. For example, I'm at a medical facility that's affiliated with the university, so we have access to retinal ophthalmologists who come through our clinic, and we also have electrodiagnostic testing. We have all of the instruments available on hand. Whereas if I'll say in quotes, doc on the block optometrists, they might not have access to all of the clinical tests that would be important for a patient's complete diagnosis and as accurate of a prognosis as we can provide. So in those cases, I think it is very important that for optometrists, as that first line defense, to be able to identify that there is something wrong, and to be able to refer that to someone nearby who can do that complete workup for the patient and all of that clinical testing that is needed in addition to the genetic test. And I would say, FFB has an excellent list of retina docs on the website. That is a good place to start.
Well, thanks for mentioning that, Rachelle. So, Rachel, a patient may go through multiple visits with multiple eye care professionals before they end up in your chair. But then there may be times that you refer an IRD patient on. Can you talk about those?
Yeah, I want to first come back to what Rachelle said and say I get so many direct referrals from optometrists that are spot on. And even if there's just a question, hey, I think this might be hereditary, can you take a look? I mean, we're always happy to do those evaluations. I am struck by the number of people who, by the time they get to me, have not heard about low vision as a specialty that they should know. So I'm grateful for my many Boston and Metro Boston colleagues in that field. I see somebody I refer to a lot attending tonight, and thank you. And the value is that I can't help people with their day-to-day vision and playing bridge or whatever the task is that they want to do with more ease. So I'm grateful to my low vision colleagues for filling that role. And it's kind of an automatic checkpoint for me when I see an IRD patient. When's the last time you saw Dr. Lin? Are you struggling more with anything that you think going back to her could help you with?
And as a follow-up question, Rachel, is there a particular resource for low vision that you recommend, or do you just have contacts you've already established in your area for referring on to low vision?
Yeah, I would say the latter. I know the folks in my own department. I know people elsewhere, so it's kind of been a network over time.
Okay. And Rachelle, on that note, is there a resource or certain credentials that you think are important for, let's say, an MD who's referring somebody on to low vision that they should consider? Because there are a lot of optometrists out there. There are a few that do low vision. Some may be better than others. Are there certain credentials that you look for?
I think any of the big academic institutions, any of the schools of optometry, they all have very rigorous low vision departments. So if you refer to any of those, you're going to find a good team there. And there are many optometrists who have completed a residency in low vision rehabilitation. So if you see that, then this is a doctor who has spent an extra year specifically training in low vision rehabilitation. But that doesn't mean that a provider who's done low vision rehab for a long time and doesn't necessarily have that residency can't provide that care.
Right.
So, yeah. Another resource that can be a very good referral is to refer additionally to the State Department of Rehabilitation, because some insurances don't cover low vision rehabilitation. And if the patient is able to go through the state services, the state will then refer to a doctor who can do that low vision evaluation.
Right. Thank you. So during your presentations, there was a quick mention of referring on to mental health support. Is there anything you can say, Rachelle, more specifically about what kind of professional you might refer somebody on to for mental health?
I don't have strong opinions on this. I think it can be a PhD psychologist. It can be a social worker. There are all kinds of expertise that offer a lot of value. I warn patients that they need to find a fit that's good for them, and they may not find that fit with the first person they talk to.
I find that patients feel they can connect best to someone who knows about vision loss specifically, because dealing with mental health with regards to vision loss is very different from other types of depression, for example. Luckily, within my institution, we have two excellent technology specialists who both have IRDs as well. And being able to just speak with another person who has an IRD and who's living through that and has gone past these barriers and they're thriving and working, that can be very helpful for patients. So in addition to those professionals, I always encourage patients to reach out to low vision networks. And again, a good place to start is, for example, FFP local chapters, so they can meet other people and support each other.
To that end, if I may, sometimes I just hear wonderful conversations in my waiting room between people, sitting there a long time waiting for me, and someone will come in and say, "Wow, I feel so much better after talking to so and so, who's been at this a lot longer than me." And those are nice things to see happen.
Yeah, I think both your comments are really important. These conditions are rare, and many people don't make contact with other people with a similar condition. And whether it's, again, in Rachel's waiting room or through a foundation chapter, that commiseration can be huge, just to find somebody who's going through a similar challenge. And we have a list of our chapters at fightingblindness.org at the top of the homepage. There are somewhere in the neighborhood of 45 foundation fighting blindness chapters out there in communities across the country. There's another question that came in that I think is really an important question. And traditionally, when patients see an eye care professional and they have a rare retinal disease, an inherited retinal disease, often they're not given a lot of good information or a lot of hope. And I'm just curious, for both of you, tell us what your messaging usually is for somebody who's newly diagnosed with somebody with RP or Stargardt disease.
You want to start, Rachelle, or either way?
Sure. That's a very good topic. I think there's both the need to have the patient have hope for the future, right? That is primary to our low vision evaluation. We want the patient to never give up hope. And the hope is for several different things. On one hand, there's the hope for a treatment. Of course, it would be amazing if we could tell every single patient that there's a treatment waiting for you in 5 years. We know that that's not the case, right? But there have been amazing strides and there continue to be amazing strides. So we tell the patient, yes, we want you to stay up to date. We want you to have access to the latest and greatest when it pops up. We want you to keep seeing your doctor for your annual eye exam so we can tell you what's available if there's a clinical trial that pertains to you. That's why we want to get your genetic testing done today. But at the same time, while we're waiting for that science to advance, we don't want to put all of our hopes on that, right? At the same time, I want you to get access to resources. I want you to keep working. I want you to keep going to school. I want you to use the low vision rehabilitation devices, because we're not just going to put your life on hold until a cure comes.
Yeah, that's so well said. It's this balance between, our well-founded and legitimate optimism and hope for what is coming, and the need to live, rich and fulfilling lives in the now, and striking the right balance where we're not forgetting that latter part, making sure that everything is in place that's needed for the day-to-day.
Right. Thank you for those replies. And that's a big part of what we do at the foundation, is try to communicate hope through the advancement of research. There's a lot of great therapies moving into clinical trials. We have a lot more work to do, but that creates a lot of hope. There's another question that's come in regarding Stargardt disease, but I'd like to open it up to really any inherited retinal disease. And I guess this might be more for you, Rachelle. Obviously, there are accommodations, magnifiers, glasses that filter out light, certain kinds of light frequencies. Is there anything people with IRDs can do to either improve their eyesight or even just learn how to use their existing eyesight better? I guess I'm talking about rehabilitation of some kind.
Sure, it really depends on the patient's individual eye condition, right? If it's central versus peripheral, if they're having mainly difficulty with visual acuity, or if the difficulty is with contrast. So I would always say to the patient, number one, get into a low vision provider so they can see exactly how your vision is being affected. Not just anyone with Stargardt's, but how is Stargardt's specifically affecting your vision? And for someone, in this case, who has central macular changes, can they use that peripheral vision more effectively? Would they benefit from eccentric viewing training, for example? So that is something that we could pursue with that individual patient.
Great. Yeah, I've heard of scenarios where a rehab professional or a low vision professional can help somebody read better, let's say with their existing vision, and not necessarily using a magnifier, but just helping them with a different approach to reading text on a page. So yeah, those options are out there. We're getting toward the top of the hour. We have just a few minutes left. Rachel, Rachelle, are there any other words of wisdom you want to share before we conclude things and have Michelle Glaze say a final word or two?
Yeah, so I think taking care of patients with IRDs is such a team effort. I can't do it by myself. Rachelle can't do it by herself. And with greater availability and successive genetic testing, with therapies on the horizon, it is such a moment to build these local networks of professionals really with the same goal so that we can really efficiently and expertly bring our care to these patients.
Yeah, I agree. And to build on that, when we have this team approach, one thing we have to be cognizant of is we don't want the patients to feel like they're getting shuffled around from office to office for no reason. So when we make those referrals, I think it's important to explain to them the reason for seeing another professional, and what they would benefit from that visit, and letting patients know we want you to have as many resources as possible. So it's not unusual that you're going to have your PCP working with your retinal ophthalmologist, working with your anterior seg ophthalmologist, with your low vision optometrist, all together to provide you with all the resources.
Well, thank you to you both for the unwavering commitment you provide, the time and energy you give to each IRD patient to help them get on a good path. And with that, I'll hand it back over to our host, Michelle Glaze.
Thank you, Ben. And thank you, Dr. Huckfeldt and Dr. Lin, for such a robust and important discussion about best clinical practices for patients with inherited retinal disease. Your expertise is vitally important. And we're so excited and grateful that you joined us tonight to share all of this information. I want to also thank you, Ben Shaberman, our VP of Science Communications, for always being an amazing moderator, and behind the scenes to Andrew and Chris. As an individual with an inherited retinal disease myself, I can't emphasize how important all of these pieces are for the care and management of patients with an IRD. It's vitally important that as an individual who is going through this journey with vision loss, we know about all the resources available to make our lives successful, to have independent functionality today, and to know about all the things that we can utilize and tap into to thrive in life and make life enjoyable and experience things we want to experience. That piece, the community piece, is so important. so that we can connect with others who understand and walk through this journey with us. So please continue to connect your patients with others who get it, both professionals and individuals with retinal degenerative diseases. And then the hope piece through the research. It's just such an amazing inspiration to know that there is a reason to be optimistic for the future. So with that, I want to thank everybody on the call tonight for joining us. If you'd like more information, please visit fightingblindness.org. Click on the Eye Care Professional tab. We will have the recording of this session available, and we're always open to connecting with you to share more. So thanks, everyone, and have a great evening.